Hey everyone, and welcome right into the explainer. I am so glad you're here today because we are going to completely decode the journey of an IV drop. If you're gearing up for nursing exams, or honestly, if you just want to really grasp the nuts and bolts of what happens when a patient gets hooked up to an IV line, you are in the exact right place. We're going to break down the absolute fundamentals of IV therapy so you can really visualize and, more importantly, retain exactly what you need to know.
All right, let's look at our roadmap. We are covering what IV therapy actually is, the types of cannulas, the very essential PVC color codes, how to spot IV complications, and we'll wrap it all up with fluid calculation math.
So, Section 1, what is IV therapy? Let's set our baseline.
Now, what's super interesting here is just the sheer difference in volume. When we talk about an IV injection, you probably picture a small syringe just pushing maybe 5 to 10 milliliters of meds straight into a vein. It's fast, it's a tiny dose, and boom, it's done. But IV therapy, that is a completely different beast. We're talking about sustained delivery here. We're setting up a dedicated line to infuse massive amounts of fluid, like 500 to 1,000 milliliters, over several hours. Think of those large bags of normal saline just continuously dripping into the bloodstream. It's really about establishing this reliable, long-term pathway right into the body.
And setting up that line actually serves two huge purposes. First up, it creates this rapid, direct highway right into the cardiovascular system. So if a patient is incredibly dehydrated or needs meds right this second, this is literally the fastest route possible because it joins the flowing blood instantly. But, and this is key, it's not just a one-way street. It also gives us a pathway to pull things out. When you first insert a cannula, it lets us draw blood samples for testing. You'll hear this called venipuncture or phlebotomy in the field.
Moving right along to Section 2, types of cannulas. Let's visualize our tools.
Okay, so let's compare two of the major heavy hitters. On the left, we've got the PICC line. That's the peripherally inserted central catheter. You put this in the arm, usually the basilic or cephalic vein, but the tubing travels all the way up and sits right in the superior vena cava, right near the heart. It's absolutely perfect for medium-term care, like that 2 to 6 week sweet spot. But check out the right side, the CVC, or central venous catheter. The big difference here is depth and duration. A CVC goes directly into the neck or chest, into the jugular or subclavian veins. We use this for the heavy-duty long-term stuff lasting more than 6 weeks. Basically, the larger the vein, the harsher the medications it can handle without tearing up the blood vessel.
Section 3, PVC cannulas and color codes. Consider this your cheat sheet.
So, PVCs. These are the standard cannulas that go right into the arm or the hand, and you will see these constantly. But there are some strict ground rules. First, they are strictly short-term, under 2 weeks only. Second, and please remember this, they are meant for isotonic or nicely balanced fluids. If you try to run harsh, super concentrated hypertonic stuff, like a big dose of potassium chloride, through a tiny peripheral line, it will literally destroy the vein. I mean, it can ruin the line in just a few hours. Also, take a look at that last rule. Always, always avoid the antecubital vein. That's the ditch right at the bend of the elbow. Why? Because every single time the patient bends their arm, that line is going to kink or completely dislodge.
All right, time for the ultimate exam hack. In any hospital, PVCs are color-coded by their gauge, which is their size. Now, quick reminder, in the medical world, the smaller the gauge number, the bigger the actual needle. To lock this into your memory, use this little rhythmic mnemonic. OGGPBY. Orange, gray, green, pink, blue, yellow. Orange, gray, and green are your big 14, 16, and 18 gauges. These are basically massive pipes for emergencies when you need to dump a huge volume of fluid into someone fast. And green, the 18 gauge, is your absolute gold standard for blood transfusions, simply because it's wide enough that it won't crush the red blood cells as they go through. Moving down, pink and blue, the 20 and 22 gauges, those are your everyday, daily practice sizes for normal fluids. And lastly, yellow, the little 24 gauge, that's strictly reserved for pediatric patients. Take a mental screenshot of this, you're going to use it all the time.
Okay, Section 4, IV complications and solutions. Let's talk about troubleshooting those inevitable roadblocks.
This is a classic exam question right here. We're looking at infiltration on the left. This happens when the needle accidentally pokes right through the vein, and all that IV fluid just starts leaking into the surrounding tissue. The skin is going to look swollen, it'll feel kind of fluffy or bouncy, almost like a water balloon, and this is the kicker. It will feel noticeably cold to the touch, because room temperature fluid is pooling under the skin. Now on the right, we have thrombophlebitis. Thrombus means a clot or blockage, and phlebitis is vein inflammation.
With this one, the area gets red, it's painful, and crucially, the skin will be hot to the touch because the body is launching an inflammatory response. Hot versus cold, that is your absolute dead giveaway to tell them apart. So what's your next move when you see these signs? For infiltration, step 1, stop the IV fluid immediately. Then you change the site entirely, and you use a warm technique, like a warm sponge, to help that tissue absorb the leaked fluid and bring the swelling down. For thrombophlebitis, it's a pretty similar vibe. Get that irritated catheter out right away. But when you put the new one in, go to the completely opposite hand or arm. You have to give that inflamed vein a break. And once again, use warm sponging or some specialized ointments to calm that inflammation right down.
But hey, what if things get really serious? What if a tiny piece of that plastic cannula breaks off inside, or an air bubble gets into the line and starts moving through the vein? That, my friends, is an embolism, and it is a massive drop-everything emergency, because if that bubble or piece of plastic hits the heart or lungs, it can be fatal. If you even suspect an embolism, you run this two-step protocol. Step 1, slap a tourniquet tightly on that limb immediately. You want to trap that moving obstruction before it goes anywhere. Step 2, get the patient into the Trendelenburg position. So lay them flat, tilt their feet up higher than their head, and roll them onto their left side. That specific angle actually helps trap the air or the plastic right in the lower chambers of the heart, which stops it from shooting up into the lungs.
All right, Section 5, IV fluid calculation. It's time for the math.
If you take away literally nothing else from today, burn this golden formula into your brain. Every single IV drip rate calculation you're ever going to face, whether it's on a test or on the hospital floor, comes down to these three things: total volume in milliliters, multiplied by the drop factor of your tubing, all divided by the total time in minutes. And don't worry, the drop factor, which is just how many drops make up 1 milliliter, will always be given to you. It's usually 15 for standard stuff or 60 for microdrips.
Let's actually walk through a real-world example so you can see it in action. Say a doctor orders 1,000 milliliters of normal saline to be given over 2 hours, and you're using microdrip tubing with a factor of 60. Let's just plug it straight into the formula. Total volume is 1,000. Multiply that by our drop factor of 60. Then we divide by the time in minutes. 2 hours, that's 120 minutes. So 1,000 times 60 divided by 120. Do the math, and it flawlessly lands you at exactly 500. You'd set that drip rate to 500 drops per minute. It's simple, it's clear, and you'll get it right every time.
All right, now I'm turning it over to you. Here is your challenge. Let's say you need to give a patient 500 milliliters of fluid spread over 12 hours, and you're using a drop factor of 60. How many drops per minute are you going to set? Grab some paper, plug it into the golden formula we just went over, and drop your answer down in the comments. I really want to see who nails this. Knowing IV therapy inside and out is exactly what separates good practitioners from great ones. Thanks so much for hanging out with me on this explainer. Keep learning, keep asking questions, and I'll catch you in the next one.